Next speaker, Ourania Preventza. And she's going to continue on here with the arch reconstruction.
Thank you, Rod. This is actually almost a complimentary talk for Rodney White in the beginning. I would like to thank Vanki for this kind invitation. It's really actually pretty emotional for me to come back here. I trained with Dr. Dietrich a long time ago, and actually I was the second cardiac surgeon that he trained early on. Thanks, Vanki, for being here. This is my disclosures. So what Vanki asked me to talk about is hybrid reconstruction. So we're going to talk about the hybrid as well as, especially for patients that they had prior ascending hemoty repair. Let me just go back. So why actually we care? We care because if we see, this is from the Arch International Aortic Hemoty Database, the in-hospital mortality, and again, this is in specialized hemoty centers. The mortality can be more than 10%, as well as the neurologic deficit can be more hemoty than 6.7 hemoty%. And again, the important thing here is this is in specialized hemoty centers. So in hands for people that they do this, for living and every day. And you have seen this slide before. Actually, I keep showing this slide because I consider it as a sign of respect as well as gratitude to the people that they did something a long time ago when they didn't have the things that we have here today in our hands. This is Nikolai Volodos. He did the first hybrid procedure in a 41-year-old hemoty female with a pseudoaneurysm for a prior coarctation hemoty repair. And what actually Dr. Volodos hemoty did is what actually lately we have done quite a few years ago we used to do, coming from above and below and deliver hemoty the stent graft. And we have to think that he did this actually in 1991, and he published that. 17 years after the procedure, he was at Arizona Hemoty Heart with Dr. Dietrich at the time in 2013, and he showed the long-term hemoty follow-up hemoty of this hemoty patient. And this is Nikolai Volodos when he presented this, what he used actually early hemoty on during his all these efforts to do the pseudoaneurysms and the arch hemoty aneurysm, the balloon catheters. Then this is the first experimental hemoty stent graft hemoty that he used. Then this radial zigzag-shaped stent. That was in 1983, and the patent that he had hemoty at the time. Now, when we did hemoty, the guidelines, the ones that Koselli mentioned hemoty before last year. So for the arch aneurysm still, this is a class 1 indication that the open repair is hemoty recommended. And what we see with regards to the endo repair or the hybrid, this is really a hemoty 2B recommendation. This is high risk this is for patients really high risk for open hemoty repair. One thing to mention here, hemoty, about these guidelines is that this is a living document, which actually means that in a few years hemoty will be able to update that, and I'm not actually surprised if some of these recommendations as the technology evolves change. But for the time being, it's still a hemoty 2B recommendation. This is something that we did hemoty a few years ago with Dr. Koselli, was when we looked at the zone 0 hybrid hemoty arches, and that was for patients that they use hemoty in zone hemoty 0 as a proximal landing zone. We can see the stroke rate can be quite hemoty high. One of the issues was the retrograde hemoty dissection. And when we look actually the hybrid versus the open repairs, the permanent stroke actually was a little higher on the hybrid than the open hemoty repairs. This is something that we actually presented on the American Association for Thoracic Surgery quite a few years ago when I was in Houston. And we compare hemoty open repairs with the hybrid. Again, the hybrid are patients that they've been much hemoty higher risk. But when we look the propensity among hemoty, both hemoty groups, we found that the overall stroke was actually higher in the hybrid group compared with the open group, and something that makes sense, especially that we found that really like the choice of technique did not affect the permanent adverse outcome. But the higher stroke rate, especially in these patients that they have atherosclerotic arches, etc., makes the wire manipulation and the catheter skills mandatory for operators. So regarding to patients that they had prior ascending repair, this is a very interesting category. This is from mine and colleagues from Europe. We'll see here that they review all the images of patients that they have prior ascending repair. And they found that more than 70% of patients were anatomically suitable for the inner branch endograft. And the major exclusion points were patients that the ascending graft was too short. That was the highest, followed by the major kink of the ascending graft as a factor to limit the endograft. And the last point was that the graft was actually too large at a time. And the good point about having an ascending graft, as of course you can imagine, is that there's no risk for a retrograde dissection. That was one of the really things that we are afraid when we clamp the ascending aorta if there's no ascending graft in place. This is from it was published in SBS last year, where we see here that they look 101 postoperative scans, and they evaluate the anatomic applicability. And they look all the devices. This is actually from Austria, this paper. And they look the Cook device, the Rumon, Ahuta, Endospan, Medtronic Mona Lisa, the Gorta graft, etc. So what the authors found that the best, actually the most favorable devices were the fenestrated and the branch devices, better than the single devices. But if you use the combination of all of them, this was the most favorable. No. And was a point here from the surgeons how you have actually to try to use a long strain graft in the beginning. Of course, this is much easier to be said after the procedure, because sometimes, when we have somebody with a type A dissection, most of the surgeons, the major thing that they think when they do the procedure is how to get the patient alive than just, what the graft is going to be. This is a patient that we did a few years ago with Dr. Coselli. Was a patient, 32-year-old Marfan, had a prior extent 1, presented with acute type A dissection. So we did a hybrid procedure, and then we placed a stent graft from below. This is another patient, again, Lois Ditch. On this patient, the vertebral was coming off the arch, and then we had to revascularize the vertebral and then do the hybrid procedure as well, placing a stent graft across the arch. And you can see here the imaging studies. So as a conclusion, all these emerging technologies is really a way to potentially offer better and less morbidity for the patients and alleviate the mortality. Of course, the strategy by having a longer straighter graft in the beginning of in the first procedure is something that we have to be cognitive about. But again, it's easier to be said after than during the procedures, because some of these patients, especially on the initial stage, can be quite sick. And of course, collaboration with industry can be extremely important. Again, thanks to Vanki and the whole committee for this kind invitation, and this really a privilege to be here. Thank you.